Welcome to the Dub Dive. Today we're tackling a real bread and butter topic, something super common. You'll definitely see this, especially if you're around kids or, in busy places. We're diving into infective conjunctivitis.
Yeah, or pink eye, as most people know it.
Exactly, pink eye.
So let's pin down what we mean. Infective conjunctivitis is basically inflammation of the conjunctiva.
That thin membrane lining the eyeball and inside the eyelids, right?
Precisely. And the key word here is infective. So it's caused by a bug, usually a virus or bacteria.
Leading to those, red, maybe sore eyes, often with some discharge.
Yeah, and we're specifically focusing on the infective kind today, just to keep things clear, because other things can cause red eyes too.
Good point. And it's useful to remember there are sort of two main culprits, viral and bacterial.
That's right.
Now, bacterial, some types might clear up on their own, but others can be, more serious.
And viral ones, they usually run their course, but sometimes the effects can linger a bit.
Okay, so our aim today, give you a really solid, easy to remember overview.
Yeah, think of it like a quick audio revision guide, hitting all the key points on infective conjunctivitis.
Perfect for a refresh.
Okay.
Let's jump in. Infective conjunctivitis, pink eye.
Got it.
Inflammation of that conjunctiva caused by an infection, typically viral or bacterial. Result, red, sore, sometimes sticky eyes. Simple enough.
Sounds about right.
Yeah.
So, think about the causes, the etiology.
Yeah.
What are the actual culprits?
Good question. What germs are we dealing with?
Well, the big categories are viruses like adenovirus, which often causes colds too, and bacteria, things like Staph aureus or Strep pneumoniae, which, often live on our skin anyway.
Right.
And less commonly, you might get fungi or even parasites involved, but they're much rarer.
Okay, so let's focus on bacterial conjunctivitis for a bit. What are the real giveaways? What makes you think bacteria?
The absolute classic sign for bacterial is a purulent discharge.
Purulent mean?
Thick, often yellowy, sometimes greenish. Definitely not just watery. It's what causes that stuck-together eyelid feeling in the morning.
Ugh, yeah, when you can barely open your eyes.
Exactly that. If a patient describes that, bacterial should be high on your list.
Okay. Now, within bacterial, are there, different levels or types?
Yeah, definitely. We often talk about simple bacterial conjunctivitis first. That's usually caused by those common bugs we mentioned, Staph aureus, Staph epidermidis, Strep pneumonia.
The skin ones.
Yeah, and Haemophilus influenza is a big one in kids too. The signs are that general red eye, discomfort, the thick yellow-white discharge, and the morning stickiness.
And are there things that make someone more likely to get this simple type?
Sure. Risk factors include things like a blocked tear duct, because the tears can't wash things away properly.
Makes sense.
Also, having an ear infection or a sore throat, suggesting maybe a bug is floating around, being exposed to others with pink eye, obviously.
Right.
Eyelid problems, dry eyes, being immunosuppressed, or even just, minor trauma to the eye.
Yeah, okay. That covers the more common stuff. But you mentioned some bacterial infections can be more serious. What about gonococcal conjunctivitis? Sounds nasty.
It really is. Gonococcal is an emergency. It comes on fast, hyperacute. You see intense redness, really swollen eyelids, tons of thick, pus-like discharge.
Wow.
And it can affect the cornea itself. That's keratitis. You might also feel swollen glands, lymph nodes just in front of the ear.
And the cause?
Neisseria gonorrhoeae, the bacteria that causes gonorrhea. The real danger here is that it can invade the cornea, cause perforation like a hole, and lead to serious vision loss if it's not treated urgently.
Okay, red flag condition then. What about chlamydial infections? I heard they're a bit different.
Yeah, chlamydial conjunctivitis tends to be more chronic, sort of grumbling along.
So not that sudden onset.
Not usually, no. A key clue is often a persistent, kind of stringy, greenish discharge, maybe worse in the mornings.
Stringy, okay.
And if you look closely, you might see these little bumps called follicles, especially on the inside of the lower lid, maybe some blood vessel growth onto the top part of the cornea. We call that pannus. And again, possibly palpable lymph nodes near the ear.
And the cause?
This is chlamydia trachomatis, but specific types D through K. It's often linked to sexual transmission.
Right. And there's trachoma. That's a major global health issue, isn't it?
Absolutely. Trachoma is also caused by chlamydia trachomatis, but different types, again, A, B, and C. It's a huge cause of preventable blindness, especially in areas with poor sanitation.
How does it cause blindness?
It leads to severe scarring on the inside of the eyelid. This scarring can pull the eyelashes inwards, so they constantly rub against the cornea, scratching it and eventually causing opacity and blindness. Really devastating.
Wow. Okay, and the last bacterial one on the list was Ophthalmia neonatorum, newborns.
Exactly. Conjunctivitis in a baby within the first 28 days of life. It could be caused by those common bacteria, Staph, Strep, Haemophilus, or by chlamydia, or sometimes gonorrhea, passed from the mother during birth.
And the key thing for newborns is?
Urgent referral to ophthalmology.
Yeah.
Because a baby's eyes are so vulnerable, any conjunctivitis needs expert assessment straight away.
Got it. Okay, that's a really thorough look at the bacterial side. Let's switch to viral conjunctivitis. What are the main clues there?
Viral typically presents with a serial discharge, so watery.
Water, okay.
Often, the person has just had, or currently has, an upper respiratory tract infection. A cold, runny nose, sore throat.
Ah, the adenovirus connection again.
Exactly. And you often find those tender, swollen, preauricular lymph nodes, the ones in front of the ear. That's a big clue for viral.
What about the sticky eyes? Can that happen with viral too?
It can, actually.
Okay.
Sometimes the watery discharge can dry overnight and cause some morning crusting or sticking, so it's not exclusive to bacterial. Don't let that one sign fool you completely.
Okay, good tip. Any other clues for viral?
If someone mentions they've had pink eye before, recurrent episodes are more likely to be viral.
Right. So maybe a quick memory aid. How about bacteria is thick and sticky and viral, watery, and maybe sniffly?
I like it. Simple, memorable, captures the essence.
Okay. We've touched on risk factors, but let's just summarize them. Who's most likely to get this?
Yeah, the main risks are pretty intuitive. Close contact is number one.
Schools, nurseries, families.
Exactly.
Mm-hmm.
Shared spaces, shared towels.
Mm-hmm.
Then there's hygiene. Touching your eyes with unwashed hands is a major route of transmission.
Yep.
And just being in environments where these infections are common, like schools and daycare centers, naturally increases your exposure risk.
Makes total sense. So how does it actually happen in the eye, the pathophysiology?
Pretty straightforward, really. The pathogens, virus, or bacteria get onto the conjunctiva.
Through touching, rubbing.
Yeah, or contaminated objects. They invade the tissue, and that triggers the body's immune response. Cue inflammation.
Redness, swelling, discharge.
Exactly. That's the immune system fighting back. With viruses, the body usually clears it on its own over time.
But bacteria might need a hand.
Sometimes, yeah. The immune system might struggle to clear the bacteria completely, which is where antibiotics come in helpful.
Okay. So we know the causes, risks, how it happens. But importantly, a red eye isn't always infective conjunctivitis, is it? What else could be going on? The differentials.
Crucial point. You absolutely need to think about other possibilities. Top of the list for differentials is probably allergic conjunctivitis.
And the key symptom there?
Itch. Intense itching. If the main complaint is itching, think allergy first.
Got it. Itch, allergy. What else?
Chemical conjunctivitis, maybe they got something splashed in their eye, like cleaning fluid or smoke irritation.
Okay, so history is key there.
Definitely. And then there are other less common inflammatory conditions of the conjunctiva, but allergy and chemical irritation are the big ones to rule out.
So how do we tell them apart in practice? Using the symptom.
Yep. Symptoms are your main guide. Intense itch, probably allergic. Recent cold or flu symptoms, likely viral.
Thick, yellow discharge.
Strong pointer to bacterial, watery discharge. Could be viral or allergic, so you need other clues.
Like the swollen glands.
Exactly. Those preauricular nodes really suggest a viral cause. And remember, even the eyelids sticking together isn't 100% bacterial dried watery discharge. Can do that too.
So it's about putting the whole picture together.
Precisely. The pattern of symptoms.
Okay. Let's talk numbers. How common is this stuff? Epidemiology.
Oh, it's incredibly common. All ages get it, but especially young kids. Viral tends to be more frequent in adults. Bacterial maybe a bit more in kids and the elderly.
Any UK figures?
Exact prevalence is tricky, but estimates suggest it accounts for maybe 1% of all GP visits.
1%? That's quite a lot.
It is, and it makes up about 35%, over a third, of all eye problems seen in primary care.
Wow.
Highest rates are in kids under 7, and there's often a peak season, sort of December through April, winter bugs time.
Makes sense. And the split between bacterial and viral in primary care?
Estimates vary quite a bit, actually. Some studies suggest around a third are bacterial. Others put it much higher, like up to 3/4.
Right.
So there's definitely a mix out there.
Interesting. So when someone walks in, what are the classic clinical features you'll see and hear about?
Okay, general signs, obviously red eyes, some kind of discharge, watery or purulent. They might complain of a gritty feeling, like sand in the eye, itching, maybe some excessive tearing, possibly slightly swollen eyelids, and sometimes mild light sensitivity photophobia.
And for bacterial specifically, what might they describe?
With bacterial, the discomfort is often more burning or gritty than itchy. Mild photophobia, definitely that thick discharge, and the morning glued shut lids. Importantly, vision is usually normal.
So blurring only from the discharge itself.
Exactly, wipes away. When taking the history for suspected bacterial, you need to ask about contact lenses. It's vital.
Why contacts?
Higher risk of more serious infections, like corneal ulcers, especially with certain bacteria like Pseudomonas.
Ah, yeah. What else in the history?
Onset, duration, any over-the-counter things they've tried, any sick contacts, their job, things like that.
And on examination for bacterial, what do you look for?
You'll typically see a diffuse, uniform redness across the white of the eye. That yellow-white, thick discharge. Evidence of lids sticking. Often starts in one eye, then spreads to the other pretty quickly, maybe a day or two later.
Vision check.
Always check vision. It should be normal, aside from the temporary blur from discharge. You might also see those follicles, small bumps, usually inside the lower lid.
But you said follicles are more viral.
Classically, yes. Or atypical bacteria like chlamydia, or even toxic reactions. But you can sometimes see them in simple bacterial cases too. They're different from papillae, those larger, flatter bumps you see more in allergies or with foreign bodies.
Okay. So the simple bacterial picture is red and sticky, normal vision. Got it. Do we usually need investigations like swabs?
Generally, no. For most cases of straightforward infective conjunctivitis, it's a clinical diagnosis based on history and examination.
When would you swab?
You'd reserve swabs for cases that are very severe if it's not getting better with standard treatment, if it's recurrent. If you suspect gonococcal or chlamydial infection, or maybe in a newborn.
Right, the unusual or severe stuff. Okay, let's get to the treatment. Management, what do we do?
It all depends on the cause. That's the first thing.
So for viral.
Viral is usually self-limiting, so management is supportive. Cool compresses can feel nice and soothing. Lubricating eye drops, artificial tears can help with irritation.
Basically comfort measures while the body fights it off?
Exactly. No antibiotics needed for viruses.
Okay, and for bacterial?
Bacterial might need antibiotics drops or ointment from a doctor. For simple bacterial cases, it actually often clears up on its own in 1-2 weeks.
Oh, really? So antibiotics aren't always required?
Not strictly required for it to get better eventually, no. But topical antibiotics, like chloramphenicol or fusidic acid, are commonly prescribed because they speed up recovery significantly and reduce the time someone is infectious.
Makes sense, especially for getting kids back to school or adults back to work.
Precisely. And remember the advice for contact lens wearers. Stop wearing lenses immediately. Use preservative-free lubricants if needed. See a doctor, and don't share towels.
Good hygiene advice. And school exclusion. Usually not needed for simple bacterial?
Generally, no. Not once treatment has started, or if the child is well enough otherwise. Good hand hygiene is the key thing.
So when do we definitely use antibiotics for bacterial?
Well, they shorten the illness and improve remission rates. So you'd strongly consider them if symptoms are severe, if it's really impacting the person's life, or perhaps in healthcare workers or others where rapid resolution is important.
Drops versus ointment. Any preference?
Drops are often easier to put in, especially during the day as they blur vision less. Ointment lasts longer in the eye, so sometimes it's used at night.
And the choices. Chloramphenicol first.
Often, yes. Chloramphenicol is a good first-line broad-spectrum antibiotic for superficial eye infections. Fusidic acid is a good alternative, particularly good against Staph aureus.
What about other antibiotics?
Things like aminoglycosides or fluoroquinolones are usually reserved for more serious infections, or if there's resistance, partly to prevent widespread resistance developing.
Right, save the big guns. Any tips on actually using the drops?
Just remind patients about hygiene, wash hands before and after. Don't touch the dropper tip to the eye. And definitely no contact lenses during the treatment period.
Okay. What about treating those atypical bacterial ones, trachoma, chlamydia, gonococcal?
Ah, yes, they need very different specific treatments. Trachoma usually needs oral azithromycin.
Oral, not drops.
Often oral, yes, sometimes as a single dose depending on the program. For adult chlamydial conjunctivitis, it's typically oral doxycycline or azithromycin, sometimes with topical tetracycline ointment too.
And the scary one, gonococcal.
That needs urgent systemic treatment, usually an intramuscular injection of ceftriaxone, plus frequent saline eye washes. Hospital admission is often required.
And gonococcal in newborns?
Similar principle, prompt IV or IM antibiotics, like ceftriaxone, plus saline lavage. Needs immediate specialist care. So the treatment really varies based on the specific, sometimes more serious bacterial cause.
Very important distinctions. Okay, so once treated, what's the usual outcome? The prognosis.
Generally very good for the common types. Viral usually clears completely in maybe 1 to 3 weeks.
And bacterial with treatment.
Starts improving quickly, often within 24 or 48 hours of starting antibiotics, and usually resolves fully within about 5-7 days.
What about chlamydial?
That can be more chronic, as we said, and might take longer to clear, even with treatment.
And gonorrhoeae.
That's the one with the guarded prognosis if not caught early. It can cause permanent corneal scarring and vision loss. Prompt treatment is absolutely key.
Okay. Lastly, what can go wrong? Potential complications. Are they common?
Serious complications are rare with the standard viral and simple bacterial types, thankfully. But they can happen.
Like
Keratitis inflammation of the cornea is probably the main one to worry about. Also, chronic or recurring conjunctivitis or secondary infections setting in.
And good management reduces these risks.
Definitely. Prompt diagnosis, appropriate treatment, and good hygiene all help minimize complications and prevent spread.
Any complications particularly linked to bacterial?
Well, corneal ulceration is a risk, especially, as we mentioned, in contact lens wearers or with virulent bacteria like Pseudomonas or gonococcus. Less commonly, you might see eyelid inflammation, blepharitis, or spread to cause ear infections, otitis media. Very rarely, you could get more serious systemic spread, but that's unusual from simple conjunctivitis.
Okay, so summing up, infective conjunctivitis, pink eye, super common, usually easy to manage.
Yep.
But the key is knowing the difference between viral and bacterial, recognizing the red flags for more serious types like gonococcal, and considering differentials like allergy.
Absolutely. And knowing the right management for each type and when to worry about complications, it's about spotting the pattern.
Hopefully, this deep dive has given everyone listening a clear, memorable framework for that, especially if you're revising for MSRA.
We hope so. It covers the core knowledge you need.
And if you did find this useful for your revision, remember there are loads more resources, practice questions, all that good stuff over at passmsra.com.
And don't forget, freemsra.com for even more free revision materials and support.
Great stuff. Thanks for diving deep with us today on infective conjunctivitis.
My pleasure.
We'll catch you on the next one.